My name is Mary Beth Hamill, and I am the Executive Deputy Editor of the New England Journal of Medicine. Today I'm going to summarize a strategy for critically reviewing a report of a randomized controlled trial. My hope is that this talk will be helpful in improving your ability to read clinical trial reports and apply the findings to the care of patients, and also helpful in improving your skills as peer reviewers, for those of you who will serve as reviewers for medical journals. Before we begin, I would like to first remind us all that randomized controlled trials are the strongest study design to establish cause and effect and provide the best evidence to guide the care of patients. Randomized controlled trials are experiments where patients are randomly assigned to an experimental treatment or control. Ideally, everything is held constant except the treatment that is being studied. This allows for the purest test of the effect of a treatment. There are three primary reasons why randomized trials provide the strongest evidence of cause and effect. First, the randomization process distributes baseline characteristics across the groups equally and without bias. This addresses the problem of confounding, which is a limitation of observational studies. A confounder is a variable associated with both the treatment and the outcome, causing a spurious association. The randomization process equally distributes both measured and unmeasured confounders. It is the equal distribution of unmeasured confounders that is critical, because it is not possible to adjust for confounders that are not measured. The second reason randomized trials provide the strongest evidence of cause and effect is that they are planned experiments and they include a control group. The control group addresses both the placebo and Hawthorne effects. Patients treated with placebo often improve, likely because of expectation of benefit of the experimental treatment. In addition, observing patients can affect outcomes. Participation in clinical trials can be associated with improvement, not related to the experimental treatment. The third reason randomized trials provide strong evidence is blinding. In randomized trials, ideally both research subjects and investigators are unaware of treatment assignment. This is referred to as a double-blind trial. Blinding helps reduce bias in the care and assessment of patients. It helps prevent differences between the study arms in patients' adherence with care, in clinicians' treatment of patients, and in investigators' assessment of outcomes. I'm now going to summarize a strategy you can use to critically review a report of a clinical trial. I will focus on three areas. First, the research question. Second, the design and execution of the trial, including a review of superiority and non-inferiority designs and aspects of internal and external validity. Third, the reporting of the trial. The first step in critically reviewing a report of a clinical trial is to evaluate the research question. You need to ask the following. If the author's conclusions are correct with the results of the trial, that is, the answer to their question, affect clinical practice or advance research field? Are the hypotheses tested and the study findings important, novel, and relevant? The answer to these questions are crucial in deciding if the trial report has relevance to you as a clinician or to a broader audience if you are serving as a peer reviewer for a medical journal. I will now discuss several aspects of the design and execution of the trial. The first step in assessing the design of the trial is to identify the interventions compared and the primary outcome measure for the trial. Next, determine the specific hypothesis that was tested. Most clinical trials are designed as either superiority or non-inferiority trials, depending on the hypothesis being tested. A superiority trial assesses whether one treatment is better than an alternative treatment. Superiority trials often compare an active treatment with placebo or usual care. The null hypothesis is that the two treatments are equal. The investigators hope to demonstrate that the active treatment is better than placebo and therefore has clinical efficacy. The experimental treatment will be deemed superior to the comparator if a statistically significant benefit is observed on the primary outcome measure. A superiority trial is generally considered positive when differences between the arms for the primary outcome measure are statistically significant, with the criterion for significance most often set at a p-value of less than 0.05. Before describing an example of a positive superiority trial, given that trial results are often reported using confidence intervals, I will briefly review the relationship between p-values and confidence intervals. 95% confidence intervals correspond with p-values of 0.05. Similarly, 99% confidence intervals with p-values of 0.01. For risk ratios, such as relative risks, odds ratios, hazard ratios, if the 95% confidence interval does not include 1, then the p-value is less than 0.05. Shown on this slide are two sets of 95% confidence intervals for a relative risk of 2. The first example includes 1, and the second does not. For percentage differences, if the 95% confidence interval does not include 0, then the p-value is less than 0.05. Also shown on this slide are two examples of 95% confidence intervals for a percentage difference of 30%. The first includes 0 and the second does not. I will now review an example of a superiority trial with positive results. In 2015, the New England Journal of Medicine published this report of a randomized trial of endovascular treatment for stroke. Patients who were suffering a stroke and were found to have clots occluding their proximal anterior cerebral circulation were randomized to usual care or to endovascular therapy, where the clot was retrieved and removed as shown on this slide. The primary outcome was survival to 90 days without disability. Patients randomized to endovascular therapy were significantly more likely to achieve the primary outcome, with 53% surviving without disability in the endovascular therapy group, compared with 29% in the control group. The authors concluded that endovascular therapy is superior to usual care and is an effective treatment for patients with stroke and proximal anterior circulation occlusions. The findings of superiority trials are considered negative when the differences between the arms for the primary outcome measure are not statistically significant, which is typically defined as a p-value of greater than 0.05. As already noted, this means that the 95% confidence interval cross 1 for risk ratios or cross 0 for continuous measures, such as differences in percentages. Negative trials are often more challenging to interpret than positive trials. A trial could be negative because it was underpowered, that is, too small, and therefore could yield false negative results. Negative superiority trials are typically of interest when findings have important implications for practice or the direction of future research, and they were large enough to provide a definitive answer to the research question. The information most relevant in interpreting superiority trials with negative results is the 95% confidence interval for the primary outcome measure. The question to ask is, does the 95% confidence interval include clinically meaningful differences? If yes, clinically important differences have not been excluded with 95% confidence. It is important to note that failure to demonstrate superiority may not rule out a benefit. The trial may be inconclusive. I will now review an example of a superiority trial with negative results. This trial of hypothermia after out-of-hospital cardiac arrest in children was published in the New England Journal of Medicine in 2015. Children were randomized to either normothermia or cooling to achieve hypothermia. This graph shows the body temperatures over time, with the red line showing average temperatures for the control group and the blue line for the hypothermia group. As planned, the body temperatures were about 4 degrees lower in those randomized to hypothermia. The primary outcome was defined as survival with good neurologic recovery. As you can see on this slide, more patients achieved the primary outcome in the hypothermia group. As shown in the second and third columns, 19.6% in the hypothermia group and 12.3% in the normothermia group survived with good neurologic recovery. The absolute difference was 7.3% in favor of hypothermia. However, the difference was not statistically significant, with p equal 0.14. As shown in the second to last column, the 95% confidence interval for the difference spans negative 1.5% to positive 16.1%, which means that the trial did not exclude a benefit as large as 16%. This is an example of a negative trial that some would argue was not conclusive. It is often sufficient to demonstrate that a treatment does not have worse efficacy than a comparator treatment, because the treatment has other advantages, such as convenience of oral dosing rather than intravenous dosing, less toxicity, or lower costs. Non-inferiority trials assess whether the efficacy of a treatment is not worse than an alternative treatment. The non-inferiority margin is defined in advance. For example, a non-inferiority trial could aim to establish that a new treatment is non-inferior if it is not more than X% worse than an existing treatment. The choice of the non-inferiority margin is subjective. You need to decide if you think the investigator's choice was appropriate. For example, a 10% absolute difference in mortality would be clinically important, and in general, 10% would be too large a non-inferiority margin for mortality. This figure illustrates a hypothetical non-inferiority trial. The primary outcome was 30-day survival. The percentages along the bottom reflect 30-day survival in the treatment group minus 30-day survival in the control group. Positive numbers to the right of 0 indicate that survival was better for the treatment group, and negative numbers to the left indicate that survival was better for the control group. The non-inferiority margin was set at 3%, as is shown in red. The investigators decided that if the treatment was not more than 3% worse than control, the treatment would be deemed non-inferior. This is determined by a 95% confidence interval that does not include negative 3%. The horizontal bar labeled non-inferiority is a 95% confidence interval for a result consistent with non-inferiority. Note the 95% confidence interval does not cross negative 3%. The bar labeled superiority reflects a result consistent with both non-inferiority and superiority. Note the 95% confidence interval does not include 0. I will now review an example of a non-inferiority trial published in the New England Journal of Medicine in 2014. This trial tested a novel antibiotic for skin infections. Iridovancin is a novel antibiotic active against gram-positive bacteria, which has a prolonged half-life, allowing for infrequent dosing. Adults with acute bacterial skin infections were randomized to a single dose of intravenous iridovancin or 7 to 10 days of intravenous vancomycin. The primary outcome was control of infection without rescue antibiotic. The researchers asked, is a single dose of iridovancin not worse than 7 to 10 days of vancomycin? The non-inferiority margin was set at 10%. Non-inferiority would be declared if the confidence interval around the difference for the primary outcome event rates between the groups does not cross negative 10%. On this slide, the first 2 columns show the percentage of patients achieving the primary outcome in each arm. The third column shows the difference between the groups of 3.4%. The final column shows the 95% confidence interval for this difference, which does not cross negative 10%. Therefore, iridovancin was declared non-inferior to vancomycin. This slide shows the same findings graphically. You can see the 10% non-inferiority margin shown in red in the far left of the slide. The 95% confidence interval for the difference in event rates does not cross this margin, allowing conclusion of non-inferiority. We will now shift to a brief discussion of common threats to internal validity. An evaluation of internal validity reflects an assessment of how well a trial was designed and executed, and it is a determination about whether the trial successfully assessed a cause and effect relationship. 3 common threats to internal validity are problems with randomization, high rates of loss to follow-up, and inadequate blinding. To assess for potential problems with the randomization, you should review the methods section to determine if it includes a description of the formal methods used to randomize patients. You can assess the success of the randomization in achieving a balance between the groups by reviewing the table showing the patient's baseline characteristics. Most typically, this is Table 1 in a trial report. Small clinical trials often have imbalances. Consider whether the imbalances were likely to bias the results in favor or against the author's conclusions. This is the Table 1 from the iridovancin trial. There are no major imbalances apparent, with similar percentage of patients with diabetes or abscesses, as highlighted in this slide. Another common threat to internal validity is high rates of loss to follow-up, resulting in missing data for the primary outcome measure. Trial reports should include a flow diagram, often referred to as a consort diagram, which is helpful in assessing how many patients were lost to follow-up and how many did not have information available for the primary outcome measure. This is a consort-style flow diagram from an anticoagulation trial. As shown in the 2 highlighted boxes, the numbers lost to follow-up were small relative to the sample size and similar in the 2 arms, which is reassuring. Ideally, you would like to have information about the primary outcome for every patient. However, there are missing data in nearly every trial, In addition to an assessment of how many patients had missing data, it is important also to consider how missing data were handled in the analyses. Is there a clear explanation and good rationale for what was done? Omitting patients without information on the primary outcome from the analyses may introduce bias. Consider how the approach to handling missing data may have affected the results and their interpretation. Did authors conduct sensitivity analyses with different approaches, and are the results similar? For example, if information on the primary outcome measure was missing for 5% of patients and the primary analysis did not include these patients, in sensitivity analyses, do the results change when all of these patients are assumed to have favorable outcomes? What if all are assumed to have unfavorable outcomes? Blinding of subjects and investigators to treatment assignment is important to prevent differential treatment and evaluation. In reviewing a clinical trial report, you should determine whether the trial used blinding, and if so, was the trial single-blind, that is, patients blind, or double-blind, that is, patients and researchers blind. It is not always possible for patients, their clinicians, and investigators to be unaware of treatment assignment. For example, blinding is often not feasible in surgical trials. When blinding of all investigators is not possible, endpoints should be determined by assessors who were unaware of treatment assignment. Blinding is especially important for subjective measures. The results of research studies of vertebroplasty for osteoporotic compression fractures provides a good illustration of the importance of blinding. Vertebral compression fractures can cause prolonged and severe pain. Vertebroplasty involves the injection of cement into the fractured bone and has been used to control pain. Prior studies demonstrated pain improvement after vertebroplasty. These studies included observational studies with pain assessed before and after the procedure, and one randomized trial, which was not blinded, with the patients in the control group receiving no sham procedure. Based on this research, vertebroplasty was widely used and lucrative. The lack of blinding in the prior randomized trial was a major limitation due to the subjective outcome of pain. Patients' and clinicians' expectations about benefit may have influenced the outcome. I will review a double-blind trial of vertebroplasty published in the New England Journal of Medicine. This double-blind trial randomized patients to vertebroplasty or a sham procedure. Patients randomized to the control group received a sham procedure that simulated the actual procedure. The sham procedure included mixing the cement in the procedure room so that patients in both arms smelled the cement and had the same experience. This graph plots patient-reported pain scores over time for the active treatment and sham control groups. Patients who received the sham procedure experienced decline in their pain scores and the same improvement in pain as those who received the actual vertebroplasty procedure. This double-blind trial demonstrated that vertebroplasty was not more effective than sham control. These findings suggest that lack of blinding explained the apparent efficacy reported in prior studies. Trials with strong internal validity do not always have strong external validity. That is, they are not always generalizable to real-world clinical practice. Examination of the inclusion and exclusion criteria and baseline patient characteristics is helpful in assessing whether the patients included in the trial were similar to typical patients with the condition. It is also important to consider how the study procedures differed from usual practice. These assessments will help you decide if you think the findings are likely to hold up in real-world practice. I will now shift to the final topic, an assessment of the quality of the reporting of the clinical trial. High-quality reporting requires that the primary and secondary outcome measures are pre-specified and clearly defined, and that data are analyzed according to a pre-specified plan. Secondary and post-hoc analyses should be clearly distinguished from primary analyses. In general, the report should focus on results of the intention to treat analyses, which means that data are analyzed according to patients' original treatment assignment, whether or not the patients adhered with the treatment as planned. Per protocol, that is, as treated, analyses may introduce important biases. One caveat is that per protocol analyses are less likely to bias toward a null result, and therefore are often the more conservative and appropriate analysis for non-inferiority trials. It is important to assess whether the reporting of adverse events is complete and balanced. Statements such as, the drug was generally well tolerated are not informative and often not accurate. For many trials, it is necessary to acknowledge that larger and longer studies are required to fully assess safety. In reviewing the trial report, you should assess whether the authors provide a balanced interpretation of the findings. Do they give equal weight to positive and negative findings? Are the authors' conclusions directly supported by the data? In summary, your critical review of a clinical trial report should include an evaluation of whether the research question is important, novel, and relevant. Your assessment of the design and execution of the trial requires the identification of the specific hypotheses tested and of potential threats to internal validity and external validity. Finally, you should determine whether the reporting of the trial is balanced and accurate, and whether the author's conclusions are directly supported by the data. Thank you.